Hello, and welcome to our listeners around the world. This is the JAMA Clinical Reviews podcast. I'm Dr. Mary McDermott, a deputy editor of JAMA.
And I'm Dr. Kristin Walter, another deputy editor at JAMA. There were 56 episodes of the Clinical Reviews podcast published in 2025. JAMA Clinical Reviews are among the most popular podcasts published by the JAMA Network. To explore all of our podcasts, visit jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts.
We selected 3 JAMA Clinical Review podcast conversations that were particularly noteworthy in 2025. First is a conversation that I had with Dr. Robert Kushner of Northwestern University titled Managing Adverse Effects of Obesity Medications. This was published in July of 2025. New medications for obesity, such as semaglutide and tirzepatide, are highly effective, but can be associated with adverse effects that reduce patient adherence. Here is a clip in which Dr. Kushner briefly summarizes the efficacy of the incretin-based therapies, followed by a discussion of the management of the most common adverse effects of these medications.
The new highly effective medications, we call them incretin medications, and what they do is mimic 2 of the incretin hormones, that's GLP-1 and GIP, and by giving it back at very high pharmacologic doses, it emphasizes the appetite-suppressing effect of these medications. And weight loss with these medications have been, on the average, 15 to over 20%, which we've never seen before, Mary, with the older oral medications.
What are some of the common adverse effects of these medications, and also how common are they?
The adverse effects are primarily gastrointestinal, which is nausea, diarrhea, vomiting, and constipation. And they occur anywhere from about 30% up to 40% of individuals, at least in the phase 3 trials. And it's these GI adverse events that is the most important factor that may limit the adherence or the tolerability of these medications. So it's extremely important that clinicians do not prescribe the medications without counseling, because that is a setup for having patients discontinue medications primarily due to these GI adverse events.
Can you talk to us about what kind of counseling clinicians should do for GI adverse effects?
What we learned when we carried out the phase 3 trials is that we can successfully mitigate or lessen a great deal of these GI side effects by providing dietary counseling. Examples would be limiting the amount of food that one consumes, reducing fatty foods or greasy foods, planning your meals in advance so you don't go long periods of time without eating, avoiding or limiting alcohol as well as carbonated beverages. You can lessen a lot of these side effects by providing this counseling, and most of these side effects or adverse events occur usually within the first 1 or 2 days of the injection, because the injection is given once a week, and when the dose is escalated, which is often once a month.
And what are the most common GI adverse effects that you see?
The most common GI adverse effects are nausea, diarrhea, constipation, vomiting, as well as heartburn. And they occur anywhere from 25 to 35% of individuals, although they're typically reported as mild to moderate and short-term.
And do we have a sense of how many people are not able to tolerate the medicines because of those side effects?
In the trials that we conducted, of course, that's not real-world experience. It's a controlled environment. Only about 6 to 10% of participants actually drop out of the trials due to the GI adverse effects. But if we look at real-world evidence, up to 50% of individuals are no longer taking the medications after 1 year. Now, we know from those types of trials, we don't know what the cause is. It could be lack of insurance, change of insurance, if they're paying out of pocket and they can't afford it. But part of it is likely due to these GI adverse events that we're talking about.
In the next clip, Dr. Kushner discusses how best to restart the incretin-based medications in patients who have missed 1 or more doses in order to minimize adverse effects.
These gastrointestinal side effects are worse within the first 1 or 2 days of taking the medication, and then they lessen for the rest of the week. But there's something very interesting about these medications that the longer you do not take them, another interval between dosing is lengthened, those side effects can reemerge at even a more severe level. So they are intended to be used once a week, and patients do fairly well. But if you're missing 1 to 2 doses for various reasons, on a vacation, you didn't take it with you, you have some medical problems that reduces the frequency of dosing, it is very important that you may need to go to a lower dose in order to increase the tolerability of restarting it. I have many patients who will go away for a month or so on vacation, come back and go back to the higher dose they were on prior to the vacation, and they often have severe symptoms like nausea, some of them actually going to the emergency room because of vomiting and dehydration. So we have to be very careful when we restart a dose in which you've missed 1 or 2 doses.
Next up is a conversation that JAMA senior editor Dr. Karen Lasser had with Dr. Maria Papaleantiu about her review article on hypothyroidism, which was published in September of 2025. Hypothyroidism can cause fatigue, weight gain, constipation, cognitive impairment, insulin resistance, menstrual irregularities, and infertility, and if untreated, may result in serious health complications, such as myxedema coma. The following clip includes a discussion of the epidemiology and risk factors for primary hypothyroidism in adults.
How common is hypothyroidism, and what are the main risk factors?
The prevalence of hypothyroidism actually depends on several factors, including, for example, iodine nutritional status of an area. So it can range between 0.3 to 12% worldwide. Particularly, the prevalence is higher in areas with inadequate nutritional iodine levels, such as regions of sub-Saharan Africa and Asia, and it's a little bit lower in North America and Europe, ranging between 0.3 to 2%. There are several risk factors that are correlated with primary hypothyroidism, which is what we will focus on today, particularly for the most common cause of primary hypothyroidism, which is Hashimoto thyroiditis and is autoimmune. The main risk factors are female sex, with a female-to-male ratio of approximately 5:1, genetic predisposition, with hypothyroidism being more common in Asian and white individuals compared with Black individuals, environmental factors, as we mentioned, living in areas with inadequate nutritional iodine levels, and also presence of other autoimmune diseases such as type 1 diabetes and rheumatoid arthritis. I wanted to also mention that for this autoimmune thyroid cause of hypothyroidism, individuals with Down syndrome and Turner syndrome also have a higher risk of developing the disease. For non-autoimmune causes of primary hypothyroidism, risk factors include thyroid surgery and radiation therapy, pregnancy, and there are a slew of medications that are associated with increased risk of primary hypothyroidism as well.
The next clip includes a discussion about the initial dosing and monitoring of levothyroxine in adults with primary hypothyroidism.
Now, what is an appropriate initial levothyroxine dose for primary hypothyroidism, and how should patients be monitored while they're taking it?
Levothyroxine, which is the synthetic form of the thyroid hormone thyroxine, or T4, is first-line treatment for patients of hypothyroidism, and the recommended full adult dosage is 1.6 micrograms per kilograms of actual body weight per day. However, the initial dose should really be individualized, and we recommend that lower doses should be prescribed for older patients and for those who may have cardiovascular comorbidities. And the reason for this is to try to avoid overtreatment, with the initial levothyroxine dose in these individuals ranging between 25 to 50 micrograms per day. In terms of monitoring, typically we monitor with TSH. So TSH, or thyrotropin levels, are typically checked 6 to 8 weeks after initiating levothyroxine therapy. This is also recommended after switching the dose or the preparation. And once the TSH level has normalized, we recommend TSH checks annually. We also recommend that serum TSH is checked if there's a change in weight of 10 pounds or 4.5 kilograms or greater, because the levothyroxine dose is weight-based, or if the patient is experiencing any new symptoms suggestive of worsening hypothyroidism, or if there's initiation of medications that could affect thyroid function.
We will finish with a conversation between Dr. Karen Lasser and Dr. Rita Kalyani, who is author of a JAMA review on type 2 diabetes published in June of 2025. Here is Dr. Kalyani discussing screening for diabetes in adults.
Diabetes is growing around the world, and as you mentioned, estimates range anywhere between 589 million to 828 million. And so this increase in numbers really prompts us to think carefully about how we can prevent new cases from developing in the future. There are many guidelines for who should be screened for diabetes. The most common are from the American Diabetes Association and the United States Preventative Service Task Force. The USPSTF recommends screening for type 2 diabetes in adults aged 35 to 70 years who have overweight or obesity. That's a body mass index or a BMI greater than 25. And that screening should occur every 3 years for those with normal glucose levels. The American Diabetes Association, or the ADA, recommends that all adults aged 35 years and older should be screened for type 2 diabetes at a minimum every 3 years. Those of any age who have a history of gestational diabetes, who have overweight or obesity, that's the BMI of greater than 25, in most individuals or greater than 23, in individuals of Asian ancestry, along with other risk factors such as family history in a first-degree relative, such as a parent or sibling, are recommended to be screened every 1 to 3 years as well, depending on their risk status. So there's a wide net of people that could potentially be screened and benefit from early identification of diabetes.
Here is Dr. Kalyani summarizing current recommendations about first-line treatment of type 2 diabetes.
This has been the focus of much of what has changed over the past 5 to 10 years. Historically, metformin has been considered the first-line medication for people with type 2 diabetes. Metformin belongs to a class of medications known as biguanides. It's the only one in the class currently available. It is primarily what we call a hepatic insulin sensitizer. It makes the liver more sensitive to insulin and reduces the production of glucose. So it reduces hepatic glucose production, which particularly reduces fasting glucose levels overnight. Metformin is relatively inexpensive, well tolerated, has high A1C lowering efficacy, up to 1.5% to 2%, and has been around the longest of any of the oral medications that we have currently. And so metformin has been one of the first medications that was considered first line for years in our clinical practice guidelines, particularly through the American Diabetes Association and also other guidelines around the world. Over the past 5 to 10 years, we have had several new trials, what are called cardiovascular outcome trials, that were mandated by the U.S. Food and Drug Administration to demonstrate cardiovascular safety. These began in 2008, and every new glucose-lowering medication approved for type 2 diabetes has to have what's called a post-marketing cardiovascular outcome trial. What these trials have demonstrated, by and large, is not only cardiovascular safety, but several new agents in the GLP-1 receptor agonist classes and the SGLT2 inhibitor classes have been found to further have cardiovascular benefit when compared to placebo. As a result, first-line medications for individuals who were included in these studies, which were by and large those with a history of cardiovascular disease, at risk for cardiovascular disease, high risk, or with a history of heart failure or kidney disease, now have preferential treatment recommended by our clinical guidelines with SGLT2 inhibitors or GLP-1 receptor agonists that have demonstrated benefits in these populations, either as first line, concurrently with metformin, or in some guidelines, even prior to metformin. This has revolutionized the way that we manage type 2 diabetes In many cases, the guidelines recommend use of these agents with demonstrated cardiovascular kidney benefit in the SGLT2 inhibitor or GLP-1 receptor agonist classes, irrespective of the A1C levels. In other words, we might sometimes see patients in our clinic who are at their A1C targets. For most non-pregnant adults, that is often less than 7%, and yet still recommend use of these newer agents because of the benefits they have on cardiovascular and kidney reduction. It is important to note that in these trials that were done demonstrating cardiovascular benefit, more than 70% of individuals were on metformin. And so all the benefits that have been noted have usually been in the background of metformin treatment.
We hope you have a chance to catch up on or revisit all the JAMA Clinical Reviews podcast episodes from 2025. There's a link to the full episodes that we've highlighted in this episode's show notes.
In 2026, continue to look for new episodes of the JAMA Clinical Reviews podcast. For more of our podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Shelley Steffens at the JAMA Network. All the best wishes for 2026, and thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.